This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar. This seminar.
Good afternoon, everyone, and thank you for joining us today for our HealthyU webinar on gallbladder diseases. At any time during the presentation, feel free to enter any questions you may have using the Q&A feature located at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is surgeon Dr. Mohamed Abuzeed. Dr. Abuzeed practices with Mather Surgical Associates, a practice of Harborview Medical Services. He came to Port Jefferson from the NYU School of Medicine in New York, where he practiced general and acute care surgery. He also was an assistant professor of surgery at the School of Medicine and previously had completed his general surgery internship and residency there. Prior to that, he was with the Steward Medical Group in Boston and an assistant professor of surgery at Tufts University School of Medicine in Boston. He received his medical degree from Tufts University and is board certified in general surgery. Dr. Abuzeed.
Hello, everybody. Thanks for joining us and welcome. Can we start, Stu?
Yes, go right ahead.
So we wanted to talk today about gallbladders and problems. The reason I chose this topic is because it's a very common problem that happens to people. It is, while it's a common problem, it can also be confusing. It can also present in different ways, and many things can sort of present and have symptoms that crosses over with these symptoms and have a lot of pain and it causes a lot of grief trying to figure out what's going on. So it's a very nice topic to talk about, and it's very common. So first of all, what is the gallbladder and what does it do? So gallbladder is basically a bag. It's a pear-shaped small organ. It sits right underneath your liver. It's actually formed with the liver when you're an embryo. So they have a common embryologic origin. The gallbladder itself does not really make or actually do anything in digestion. It's more of a storage. It's a storage bladder. It's a gallbladder, and it stores the bile. Okay, the liver makes the bile. And you need the bile to help with digestion, especially fat digestion, some absorption of some vitamins. There are fat-soluble vitamins. You need to be able to digest fat well to be able to absorb them. So the gallbladder, stores bile that is made by the liver, and in response to certain stimuli, after you eat, especially if you eat a fatty meal, there's hormones. There are many hormones, but the one we care mostly about with the gallbladder is something called cholecystokinin, which means in addition to other organs that also affect the gallbladder, but this one is of importance. It stimulates the gallbladder to contract, and once that once the gallbladder contracts, it squeezes that bile. Now you always have bile coming from the liver to the intestines. It's not like you don't have that unless you squeeze it out of the gallbladder, but you always have a little extra in the gallbladder to help with the digestion. So that's the normal function of the gallbladder. Exactly. So obviously we're here to talk about problems with the gallbladder. So most of the time when you have a problem with the gallbladder is because the gallbladder has stones that form within it. Okay. Sometimes there is no stones, and we'll talk about that a little bit later. But most of the time when somebody has a problem with the gallbladder, it's usually because they formed stones. So now, how do these stones form? And we'll talk a little bit about chemically. I don't want to get too complicated there, but we'll talk about the risk factors later. So basically, the stones are called cholesterol stones. I mean, they are literally made of cholesterol. Now, the cholesterol is very ubiquitous in the body. We always hear about it when it's in the blood supply, in the bloodstream, and with the cardiac risks and all that. But it's also used in many other things, including digestion. And the bile that's made in the liver is made of what we call bile salts. And these are made from cholesterol. Now, there's a certain combination, and there's different types of salts in the bile. When that balance is off, okay, you have more cholesterol, and there's what we call oversaturation of cholesterol in the bile. And what that makes the cholesterol do is it makes it crystallize. So it comes out of the solution and becomes a kind of a little nucleus, and it grows as a stone, almost like a pearl in an oyster. You got a little piece of sand, and then you have a pearl grow around it. It's sort of similar in a way where you have a stone in the gallbladder, starts with a speck of cholesterol, and then it sort of grows from that. And these stones can get pretty big. You know, they can get really small. They can start small, something got a couple of millimeters, or they can get really big, up to about 1 inch, 2.5 centimeters, even bigger sometimes. And there's also a different type of stone, something called pigmented stones. So people can get stones in the gallbladder. These are usually special situations that people have problems with their blood diseases, something like sickle cell, or something like thalassemia, or something else called spherocytosis, where the turnover, where you're destroying blood cells more than normal. And these stones are made of something else, bilirubin, usually, which is a byproduct of the breakdown of the blood cells. So there's a different types of stones. So there's certain people with certain diseases like sickle cell that are prone to having stones in their gallbladder. Now, that is a little different than the cholesterol stones, which are mostly what we associate with the gallbladder. And sometimes the bile itself, due to that imbalance, while you don't really have big stones per se, but they can be almost like gravel, very fine, or the bile itself can get very thick and viscous, and we call that sludge. But they do act, for all intents and purposes, like stones. So, but that's where really how the most common way that gallbladder gets disease is by forming these stones. Next. So this is for cholesterol stones, a little bit down there for the other stones, but the most common stones are the cholesterol stones. Like I said, the people form stones for many reasons, including, we'll talk about these risk factors, but also some genetics. You know, they're common in certain populations. The Native Americans are particularly at risk to forming stones, and this is because of genetics. Our Western Caucasian population is also a risk for that, but that's also more of a lifestyle and our what we call quote unquote Western diet. And Hispanic populations are also at risk for it. In general, everybody really is at risk for this. Just certain populations, people are a little bit more prone, but anybody, any person anywhere in the world can have a stone. It can form that. So these factors include diet, of course, diet that is high in saturated fats, that is unbalanced, is also obviously associated with causing these stones. Age, as you get older, gallstones are very uncommon, very rare in children, but as you get older, the risk of having stones goes up. Female sex, so females in general are, as we're talking about biologic females, are high risk for forming these stones. It is because of the hormones, of the hormone levels and estrogen, because hormones are also made from cholesterol as a substrate very early on in the process. So you can see where you have a high level of hormones, that can also be a risk factor for causing stones. We talked about genetics, you know, people, in addition to just the populations, but the genetics in the sense that it usually clusters in families. The genetic link is not quite established yet. Like, you don't have, oh, this is the particular gene that does that. It's rare, but mostly that it is noticed that, for example, somebody has gallstones, they frequently say, oh, well, my mother, my father, my sibling, they had gallstones as well. So it does cluster in families. Pregnancy is a risk factor as well, like we talked, for causing stones. So many women can form stones while they're pregnant, and certainly having problems, if their stones become a problem while you're pregnant, it can become a very complicated way to deal with because of the baby. But as you can tell, you know, pregnancy is a situation where the pregnant woman has high levels of hormones which are needed for the pregnancy, and as a side effect, that can put at risk for causing, for having gallstones. Diabetes is another one. And you can see how if you put some of these things together, obesity is a risk factor, but that also, these are all associations. And how you can, as you can tell from looking at that list, many things feed into something else and nothing is really in isolation. For example, even though they try to do studies to figure that out for, for example, lack of physical activity, if people are not active, have been found to have high risk of having stones. So that's independent of them being obese or having diabetes. But obviously, as you can tell, many of these things, they do go together. Now, this one's, that next one on the list sounds a little bit counterintuitive, rapid weight loss. But if you lose weight, if you tell me obesity is a risk factor, but losing weight is losing fat is also a risk factor. It's really not. Gradual weight loss is not. We talk about rapid weight loss. That's usually in somebody who's, for example, has bariatric surgery, weight loss surgery, where they lose weight very, very quickly, and it's usually a significant amount of weight, or somebody in an unfortunate situation where they get ill or sick, or they're unable to take their calories, and then they lose weight very quickly, and that is usually a risk factor for forming stones. So that's all ties into that composition of those bile acids in the bile being very off, not balanced. Some medications can cause. Can be associated with an increased risk of having gallstones, just like, for example, somebody who's on oral contraceptives, they include hormones. Not everybody does it, obviously, and some of these oral contraceptive pills are low in the hormone levels, but they are not 100%, of course, but there's an association there, or somebody's on hormone therapy and some other medications. Some people are also risk for it, like people with Crohn's disease. They've been known to have a higher risk of having gallstones. It's also because of the altered way they absorb it and secrete the bile. And people with sickle cell disease. Now, all these are all risk factors for cholesterol type stones. People with sickle cell disease, for example, or the other blood disorders we talked about, are really more risk for that, what we call pigmented stones, or the bilirubin type stones. So this is a good kind of, if you go back, please, for that slide, just quickly. So this is just sort of, not all of them, of course, but a lot of them. And it's a good way, it gives you sort of a roadmap, right? So these are all the risk factors. What can I do to sort of try to protect myself from forming stones? Or if I have them, if I fit into one of those categories, what can I do to help protect myself from, to decrease that risk for me to forming these stones? All right, we can go next now. Okay, so protective factors, this is against actually forming the stones, right? This does not, once you have the stones, this is not what we're talking about, but we're talking about to help not form the stones from the get-go. Obviously, a healthy, well-balanced diet that's high in unsaturated fats down there, that it has lots of fruits and vegetables, that has high fiber, because the fiber can actually bind and hold on to these bile acids and cholesterol and these waste once they get down to the intestines, so that helps. Physical activity has been shown independently that if you increase your physical activity, your risk of developing stones is lower. And we talk about gradual weight loss. So these little three things down there, like vitamin C and coffee, they're just interesting. A lot of times scientists and people look at, is there something particular that helps or hurts a certain thing? And you hear about similar stories like that about everything in the news. But there's been a couple of studies here and that show, for example, that vitamin C helps against forming these gallstones. Obviously, we talked about the unsaturated fats, helps with that, and coffee, interestingly. So everything in moderation, though. Nothing, you don't want to overdo it on anything. All right, next. So what happens after you have gallstones? Okay, so then, like I said, gallstones are very common. Okay, and something as many as 10-20% of the population will make stones at some point in their stage of life. I mean, that's a huge number if you look at it. Not everybody's having problems, and not everybody, needs a surgery or anything like that. These stones, about 80% of people who have stones, even though it's very common, they'll have no symptoms. They don't even know they have them. You know, sometimes you get a CAT scan or something for a very unrelated problem, and then people they find that, oh, we have gallstones in your gallbladder, and people can get very worried about that. But like I said, 80% of the people, most of the people that have stones will never have a problem from them. They'll never cause you an issue. You'll never need an operation or anything like that. But you can have complications in a small number. You know, if you take those numbers, there are very huge numbers. And even though a very small number of it can tell you what's the magnitude of the problem that we have, so to speak, in the sense that 1 to 2% of the, you know, of the 10% of the population is still a very large number. So it is a very common problem still. But like I said, the risk is about 1 to 2% a year of having a problem or a complication from having these stones. So like I said, if you find you have stones, you're checking out some other problem, or you're checking something, or you're having a screening and you found that you have gallstones, but these gallstones are not causing any problems, they're not causing you any pain. Most of the time, you don't need to take your gallbladder out. You don't need to do anything about them, in the sense of treating them. Certainly, having a healthy diet, a low-fat diet, and doing the things that are protective, you know, like exercise and like eating healthy, then obviously will be very helpful. But in general, you don't have to, you know, be on therapy for these stones or have anything done for these stones. There's some special situations. I just had to, for completion's sake, to add them in there. Some people have had a heart transplant, for example, and there's some other situations with people with these blood disorders, if they're having surgery for something else, or but these are usually complicated, and these are kind of, you discuss those with your doctor, and they're on a case-by-case basis rather than a general statement. Here we're trying to stay general for this particular topic. Yeah, next. So symptoms, right? So if you do have stones and they have symptoms, so what kind of symptoms are we talking about? Okay, so most people who have symptoms from their gallstones, the symptoms are most commonly pain. Okay, so where is this pain? So if you don't mind giving me the pointer, so let's try to point a couple things here. Let's see if I can. Options. Okay, so as you can see, where the gallbladder is obviously sitting here, and then this is a zoom out. Okay, so you have stones in your gallbladder right here, and then so how do these symptoms develop? Right, so one of these stones can come out and they can get stuck here, right at the exit of the when you exit the gallbladder, something we call the cystic duct, which is right here. This is the cystic duct, and so when that happens, when the stone gets stuck here, obviously the gallbladder is now obstructed, it's blocked, okay? And especially if that happens after you eat. So a lot of times the pain is associated after a meal, but not always after a meal, especially a fatty meal. And then so the gallbladder is full of bile, but also has stones in it. It's trying to contract because it's responding to the hormones and to the meal. And it's trying to get the bile out out from the gallbladder into the intestine, through these tubes. So if you have blockage here, you can see how the gallbladder is trying to push against the wall, so to speak, metaphorically speaking. It's trying to push against that obstruction, and then you can see how that swells up. It gets very angry and causes a lot of pain. Now, most of the time if that happens, then after a while, it lasts for some time, and you can also have nausea. That pain can also be up on the right shoulder. It's a very common, what we call that, a referred pain, and you can feel it up there. A lot of times people have actually, and I've had quite a few cases come my way as well, and I've had people tell me stories. You can have that pain can actually, you can have chest pain. Many people come into the hospital, they feel like they're having chest pain. They think they're having a heart attack or something, that the problem with their heart. Turns out, after, obviously you have to make sure that's not the case, because it's very important not to, if it's a heart attack or something like that. But many times those symptoms of pain from the gallbladder can mimic and can look like that pain from a heart attack. So people can get very worried about that. But turns out it's the gallbladder. Like I said, a fatty meal is a common trigger for those symptoms, because that's what stimulates the gallbladder the most, is a fatty meal, because that's what the body's trying to do, is trying to digest the fat. But not always. These stones can be unpredictable, okay? And I've had one of my older mentors when I was a student that tell me the one predictable things about gallbladder stones is that they're unpredictable. And many people can have pain at night, and but it can come anytime. Okay. Now, once that stone falls back in, then you can see how the gallbladder can relax, the blockage, the swelling can go away, and the pain can go away. So they call that colic, because it can go and come back and go and come back, in response to eating or not. So that's why they call it biliary colic. But the pain itself is really constant when it's happening, but it can resolve. I think we have the next slide, please. Now, so as you can, if you go back to that, remember those stones, those stones are in here, right? In the gallbladder, and they can try to come out. So this is a little complicated picture. I apologize, but I tried to find the least amount. But if you can follow how the bile is trying to come out of the gallbladder, and if it gets stuck here, like we said, then you can have the pain. Now, if that stone is stuck there, it doesn't fall back, okay? And it's just stuck there. And usually about 6 hours or so is when kind of a cutoff. Then, or if it doesn't come off at all, then as you can tell, this swelling, it continues to be here, and the pain continues, and you get inflammation of the gallbladder. And that is what we call cholecystokinin. So that obstruction is here, it's persistent, it doesn't go away. If that stone were to fall back, then the pain gets better. Okay, and people usually go about their life and they check it out. But if it doesn't go back, doesn't fall back in, you can see how it can get you get a lot of inflammation, a lot of swelling, what we call edema in the gallbladder, and the pain will be severe. It doesn't go away. Sometimes we'll have fever, they'll feel ill, they're sick. And I say most of the time, you'll find people who have these symptoms, they really can't take it, and they end up going to the emergency department. And certainly that's the right place that's the right thing to do. If that happens, you don't want to sit around while you have something really bad going on, because it can go on, it can be a problem. Now, I put these couple of words, there are a little big, kind of complicated medical terms, but I just, for completion's sake, and I'll just give you a general idea of what I mean by all those. If that gallbladder, if that stone out of the gallbladder comes out and gets stuck, say, somewhere here with this arrow, right? It's actually kind of a bigger problem, because now it's not only blocking your gallbladder, but also blocking the liver. And that's something we call cholecystokinin. It means the stone is in the duct. And that can be a very high risk for infection as well. And this is usually an emergency, and people will have pretty bad pain and other symptoms with that. Also, this is your pancreas right here with the big arrow. So if the stone were to get, and as you can see, it meets with that duct that's coming from the liver. So if you have a stone that gets stuck, say, in this area right here, which is very common, then you can have something called pancreatitis, which is inflammation of the pancreas. Okay, most of the time when that happens, the stone gets stuck here for a little bit and just sort of gets on its way, and and then the pancreatitis will get better. But then when that happens, the odds are it will continue to happen. So we get worried about it. So even though you do have pancreatitis, for example, and you get better and it's all resolved, it's always recommended that you get your gallbladder out, because that is a sort of the stone factory there that's going to continue to happen. Now, these couple others, gallbladder ileus, and obviously you can have cancer in the gallbladder, just like anything else. This is not a talk about gallbladder cancer. We won't talk about that. Something called Barrett's. Sometimes you can have very big stones right here, and that can get pushed into the ducts. But these are all special situations. I wanted to bring them up for completion's sake. And but you can see how for the stones to come out of the gallbladder and cause problems, it has to be small, right? Because a big stone that's 2.5 centimeters, it's not going to be able to make it out of the gallbladder. So just sometimes human beings, we all have this idea, oh, well, if it's something small, it's better than something big. Having small gallstones is not a good thing by any stretch, because it can come out and cause a lot of big problems. So can do big stones that are just different. So you know, the size of the stones within the gallbladder is really not an indication of how bad our, you know, generally speaking, how bad our problem you can have. You can have a problem regardless. But this is sort of the spectrum of diseases you can have. Sorry if we got a little too technical in this situation. We can move on to the next. So let's talk about the, oh, can you take those arms up? So let's talk about that. So now you're having pain, you know, and you're at home, you're having this pain, either the classic right-sided pain or any kind of pain that you're not really sure. And then you go to your doctor, right? If your doctor is suspecting it's a gallbladder problem, obviously they're going to examine you, they're going to look at you. A lot of times, you know, if you go back a little bit, I'm sorry, Stu. No, go back. Not one more. So if that stone were to get stuck here, like we talked about, and it blocks the liver, for example, then you can get jaundice, you know, because the liver has to secrete all that bile, all the bilirubin, and if that is, if it gets stuck there and it's a blockage, you can turn yellow, you become jaundice. Excuse me. Can you go ahead? Back. Can we go ahead, Stu? So, you know, the history physical exam, right? So they're going to examine, the doctor's going to examine you, you know, look at your abdomen, of course. They're going to, you know, push on your belly, see if you have anything painful. They're going to look at your vitals, make sure you don't have fever. They might look in your eyes or look at your skin to make sure there's no jaundice, to figure out where are, you know, what sort of problem you're having, if you are, and if you are having, where is this stone? Is it stuck somewhere? Is it what? It gives you a lot of clues on how to proceed. From there on with the more, you know, testing bloods or imaging. So if you are, and most of the time, you end up getting some kind of blood test, usually a blood count, you know, your electrolytes and your liver function test, right? Because that can give you an idea if there's a stone somewhere, if there's inflammation, if something's stuck, if your liver okay, and coagulation. Also, you know, if you ever needed an operation or something like that to make sure your blood's not too thin or whatnot. Now, based after this step, the next step would be some kind of imaging. The most common imaging that we order for gallbladders and is an ultrasound to diagnose these problems because it's very sensitive. It can pick out those stones. You know, some people will get we'll talk about CAT scans. CAT scans are not really the best study for gallstones because gallstones are made of cholesterol, like we talked about, and X-rays in general do not pick up. You won't be able to see them because they're opaque. They're not dense; they're radio opaque, so you can't see them on the CAT scan. And but the ultrasound can. Sometimes stones can have calcium in it; they can get calcified, and you can see them that way on the X-ray or on a CAT scan. But most of the time, what's being ordered is an ultrasound, and that can give you a lot of information about the gallbladder. It can tell you if the gallbladder is distended. It can tell you if it's swollen. You can see if there's fluid around it because it's inflamed. And you can also look at these ducts to see if they're getting bigger because they're obstructed or not. So it's a very valuable first test to order and to get is that ultrasound because it gives you many information. Also does not have any radiation. And we usually are pretty good at it, our techs and reading it, and you can get a lot of information. This other tool, you know, for example, this is an MRCP, the last one. It's an MRI that can give you, it's better than an ultrasound in seeing where the stones are, but it's obviously it's a lot more involved test. It's not the best test to start with, and that you most of the time you don't need it anyway. But in certain situations you need that. And this middle one, I'm sorry, is the HIDA scan. It's good to look at the function of the gallbladder. Some rarely the gallbladder itself is not working well because of some genetic issues and it doesn't work well, this motility. You might need this HIDA scan to see how it's actually working. But most of the time, the ultrasound is all you need, and it suffices to diagnose whether you have the stones or you don't have the stones, and a little bit about the gallbladder. So that's basically the workup. You know, you see your doctor or in the ER even if that were to happen. And you get a very good idea of what's going on with the gallbladder, starting with that ultrasound. Next. So treatment. I don't have a lot of pictures here, but treatment, there's a couple different ways. Obviously, as everybody knows, almost common knowledge now, the most common way we treat gallbladder problems is with surgery. And so why would you do that? Sometimes somebody might think about, well, surgery is a pretty drastic option. You're just taking it out. So why is that the most common way to treat it. And it's almost a little counterintuitive, but surgery for gallbladder nowadays, at least, is one of the safest things you could do for a gallbladder problem. Surgery has become, with the techniques and the technology that we have, surgery for gallbladder in particular has become very safe. And obviously it cures the problem. In the sense, you take the gallbladder out, so to speak, and then that problem with the stones is no longer there. The stones are no longer there, but then somebody might come back and ask, well, doctor, don't I need the gallbladder? You just told me I need it for fat digestion and all that. And the truth is, you really don't need the gallbladder, in the sense that the liver will continue to make the bile and it will continue to go down to your intestine, and you'll continue to have that digestion. You won't have that extra push once in a while. But in general, the body adjusts, the liver adjusts, and you can live a normal, long life without needing your gallbladder to be in place. So if you look at the picture, you have the open and the laparoscopic, right? The open used to be back in, in the 70s and whatnot. That used to be the way to do it. And it's obviously a big cut. There's a lot of pain involved in it. And that still happens nowadays, but it's usually because there's a problem, that's something that precludes having the laparoscopic surgery. Usually, if somebody were to get surgery for the gallbladder, they will get that laparoscopic operation. Most of the time, people do great from it. It's a same-day surgery in most of the times. The pain is okay, usually for a couple of days, and then gets better pretty quickly, and people bounce back and recover very quickly. Then you have that robotic now. The robotic platform is being used for gallbladders. There's some advantages and disadvantages to it. We won't get to it, but it's, for all intents and purposes of our talk, the robotic cholecystectomy and the laparoscopic cholecystectomy are sort of one and the same. There's obvious differences between the two, but just for general talk, we treat them the same here. And obviously, open, usually there's a problem if sometimes a person is having a laparoscopic procedure, but for some reason there's a problem, there's a complication, there's something unexpected, then they'll require that bigger incision, because you can be right in there and take care of that problem, rather than being able to do it from a distance, so to speak, with the laparoscope. If somebody does require their open cholecystectomy, then that's obviously not a same-day surgery. Most of the time, people are in the hospital for a few days to help the pain and the recovery. But in general, even if you undergo the open cholecystectomy, with time, people heal up just fine, and they'll do great from that. So this is surgery. So this is, as you can tell, if somebody does have a problem with their gallbladder, they have stones, and they're causing them symptoms or causing them complications. Most of the time, you're gonna, if you're in contact with your doctors, or you see your doctor, or you're in the hospital or whatnot, and you do have a problem with your gallbladder that's causing you symptoms, I think the number one recommendation that somebody's going to give you is to get that gallbladder out. Again, because like I said, it's safe, it's usually well tolerated, and people do. But there are non-surgical ways to treat them in general. Now, we don't use those non-surgical ways because they're frankly not as good. And so, for example, we'll talk about observation. Observation is for people that we talked about earlier in the talk, in the sense these people have gallstones, they're not causing you problems, you never have any symptoms, you found them incidentally. Then these stones, unless you fit into one of those certain categories we talked about, you can just let them be. You have them, you're aware of them, you're vigilant if something were to arise, but you can just observe. You don't have to. I said, most people who have gallstones don't need an operation. You can just let it be. There's this medication. There's some medications that help dissolve stones. This medication called ursodiol, or actually the brand name is called Actigall. Now, we don't use that often. It's used here and there, but we don't use that often because it's really not that good at doing what it wants. For example, the success rate of actually dissolving these stones is very low. It's about 30%. And this is speaking of stones that are small. They have to be really small, and they can't be calcified. And you need about 6 months, 12 months of treatment and follow up, and to make sure that the stones dissolve. And then I said, most of the time you're not successful when you do that. And even if you're successful and you stop the medication, many times these stones will just form again. So using medication to dissolve stones it only really appropriate in very certain situations with very certain patients and certain kinds of stones. So not everybody qualifies, and even people who do qualify for it, it's not a great option, or at least not as good as an option as just taking the gallbladder out. But it is an option for the right person. Gallstone extraction, somebody have the stones in the gallbladder causing them problems. There are procedures you can go in, you can put tubes in the gallbladder, drain it, take the stone out. And these are all usually, they sound less involved than having surgery to take the gallbladder out, but actually it's quite the opposite. You only do these type of procedures in situations where you can't take the gallbladder out because somebody's unable to undergo surgery for whatever reason. And then you can sort of try to figure out other ways to help them without taking the gallbladder out. Certainly there's other procedures that take stones out when they get into the duct and whatnot, but that's we're not talking about that right now. So basically, in summary for this, if you do have problems that are if the gallbladder is your problem and you are trying to get better, most of the time, most people will have surgery recommended to them, but there are other options in situations where surgery is not feasible, not the best way to go forward based on specific patients. I think this is it for us. It's just about us. This is me with my partners. We're right here in Port Jefferson, right across from Mather Hospital. For our information or any contact, it's right there. Thank you.
Thank you, Dr. Abuzeed, for an extremely informative presentation. Again, if anyone has any questions, you can enter them now in the Q&A feature on the bottom of your screen. All questions are anonymous to protect your privacy. And let's see, we have some questions here, starting off with, after gallbladder removal, I felt some expansion in my stomach from time to time. How do I mitigate this symptom?
I'm not sure about what you mean by expansion, but most of the time, not most of the time, many times after taking the gallbladder out, especially if you had stones and the gallbladder was sort of still functional or doing well, many people can report having bloating after the surgery, usually for the initial period. Sometimes people have some diarrhea after the surgery because they're not absorbing the fat very well. But most of the time, these symptoms are very short time after surgery, and the body does adjust and does accommodate, and you sort of should go back to normal. You know, there's always an exception to the rule, and there's some people, unfortunately for them, they do have some long-term symptoms after taking their gallbladder with tolerating certain foods or not. Sometimes we say, well, I can never eat pizza again because I'll have symptoms or something like that. But most of the time with these patients, even if they have long-term problems, we can give you certain medications we can give you. There's some things that we could do to help alleviate those symptoms. And certainly we do recommend that you follow a low-fat diet, especially after surgery, in the immediate period after surgery, to help with these symptoms. But this, I'm guessing this is what you mean, is bloating and feeling these feelings. Most of the time, these are short-lived, maybe a month or a couple weeks, a month after surgery, and they do resolve. And unfortunately, sometimes they do persist, and there's some things we can do to help out with this. So certainly I would discuss with your surgeon, with your doctor, if you continue to have symptoms like that, to see if there's anything that can be done.
Another question, is there a blood test to identify gallstones?
No, not at the moment, no.
Okay. Another question, I have ongoing pain on my right side.
I apologize. There's some blood tests, obviously, that you can tell if you're having a problem related to the gallstones, like if you have a blockage or pancreatitis or some kind of inflammation. Yes, you can sort of infer you having gallstones from blood tests, but there's no direct blood test that you test it, see if somebody has stones. You can infer having stones from sort of there's a problem going on, and then these blood tests can sort of clue you, hey, well, listen, there's a problem, with inflammation here, or the LFTs are high, the liver functions are high. Then, well, maybe this person has gallstones. But there's no direct, so that's there's no direct test that tells you there's somebody has a stone.
Okay. Another question, I have ongoing pain on my right side. Could that be gallstones?
It could be, so of course, pain on the right side, like I said, the classic is the right high, up right under your rib cage, maybe up in the middle. Sometimes it goes to the shoulder, sometimes it goes to the back, but sometimes you can feel it lower. So if you're trying to check this out, just the right side of pain, of course, can be that. It has to be proven, of course, but absolutely, yes. So I would recommend you get that checked if that's something that's bothering you and you're having right-sided pain. I would make an appointment with your doctor, have them check you out, start you on the process of figuring out what's going on. Certainly, many other things can cause right-sided pain, but gallbladder is definitely one of them, and gallbladder is a very common problem. So yes.
Okay. Another bit of a long comment here. It's this person said, I had 2 episodes in 2018 and 2019. They determined I had gallstones. My second episode came about under similar circumstances, watching sports, eating junk foods too fast. This time I did not go to the hospital. I was concerned, went to a doctor. He ordered an upper GI endoscopy, which revealed gastritis, duodenitis, hiatal hernia. I have not had another episode since 2019. My questions are, should I consider having my gallbladder removed? Do I need to do anything about the hiatal hernia?
So there's a lot into that question, right? So if you do have, like I said, initially in the beginning of the talk, many symptoms can sort of overlap and some things can be confused for other things, okay? If you do have a hiatal hernia, especially if it's a small hiatal hernia and gastritis and some mild duodenitis, you have to figure out what is causing these inflammation. But most of the time, they will not cause you right-sided pain or have these episodic type pains that you're describing. Right now, if you have gallstones, and depending on the pattern of the pain, and I think it's worth a conversation with your doctor, depends on the pattern of the pain, what was going on at the time, how long did it last for, and whatnot. Then you can tease out that the pain is from the gallbladder versus it's from the your gastritis and your hiatal hernia. Having said that, if you have some gastritis and now all this, but you already have treated that, for example, you needed, I'm not sure exactly what the problem is, but I'm just saying for argument's sake here, say you had some gastritis or you had some reflux because of your hiatal hernia, but you're on the medications for that sort of has resolved, but you continue to have the pain, or if you have the symptoms, then obviously in that situation, you'll know that the pain is not from the gastritis or the hiatal hernia, rather it's from the gallbladder. And vice versa. If you're having pain that is up on the left, and that is sort of a reflux type pain, that's a heartburn type pain, that does not fit the classic description of the gallbladder pain, so that might not be your gallbladder. But I do have, most of the time, I think people overestimate the amount of pain that you get from your hiatal hernia. And whereas the gallbladder all along, and then you kind of end up going on these different tangential workups because you find something and you're trying to find out more about it, and then you forget or you're not unintentionally sort of neglect the common problem. Common problems being common. If you have gallstones and you're having these episodic pains after eating junk food, is probably your gallbladder. Because that's a very common thing to happen. Now, certainly I'm not saying that's what it is, because it's hard to say without looking at your specific case and what's going on with you. But in general, absolutely, it's worth that discussion.
Okay. Another question: are there any other symptoms besides pain and nausea, such as gas?
Well, like I said, many people can have symptoms can overlap. You can have, obviously, pain is the classic, nausea, bloating, gas as in flatulence, not necessarily, but you can have pain that is gas. People feel like gas pains, crampy pain. Absolutely, you can have that, and sometimes it can travel, it can radiate. So yeah, there's a myriad of symptoms there. We talked about the most common types that you encounter, or the most classically described ones, but absolutely, yes.
Okay. And we have one final question. Do you have to see a primary doctor first to get a diagnosis about your gallbladder, or can we make an appointment directly at your office?
Oh, with me personally, most of the time there needs to be a referral. It depends on somebody's, and we're happy to see anybody, of course, but most of the time there has to be a referral from the primary care doctors, and many times the primary care doctor before they make a referral. They'd want to work up the problem themselves. But in general, if you're able to get in and see us, we're happy to work that problem up for you without the primary care. But having said that, it's always the best place to start is with your primary care doctor.
Okay. Dr. Abuzeed, thank you again.
Thank you for having me.
If anyone has any other questions, or if you think of a question later, you can email them to us at matherhospital@northwell.edu, and we'll pass them along to Dr. Abuzeed. Once you exit the webinar, you will be redirected to complete a brief survey. We'd appreciate it if you can complete the survey. Your feedback is extremely important to us and helps us plan our future webinars. If you would like to view this webinar again or other HealthyU webinars that we have presented, you could find them on our website at matherhospital.org/HealthyU. Thanks again for joining us today, and enjoy the rest of your day.
Yeah, thank you, man.